Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis. Today I have a very special guest who's actually a friend and a patient, Heather Grobe. Thanks for joining me.
You bet. Thanks for inviting me.
Yeah, absolutely. So I thought this would be a fun, interesting episode for us to kind of see the world from the patient's perspective. So I did surgery on your foot, and so we'll get into the details of that later. But I thought it'd be interesting for people to hear about kind of your perspective and see what it's like going through that whole process from your point of view. So we'll get to that later. So as I know you, you're an ED, an emergency department paramedic, and you're also a flight paramedic. So why don't you talk us through how you became involved in those?
Absolutely. So I have been flying with Unity Point Life Flight for just under 10 years. I was a paramedic in the Marshalltown area for a few years prior to that. I actually never thought about flying. That wasn't on my radar until one of the flight paramedics, I actually taught his daughter CPR in the high school and got to know him a little bit more. And he said, well, gosh, I think you'd be a good flight paramedic. And I giggled and I said, I'm so wet behind the ears as a paramedic. I have no business flying in a helicopter and being that person that people call on to have a really broad base of knowledge and, swoop in and save the day, so to speak. And he laughed and he just said, why don't you come do a fly along with me? And so I went and did a fly along with him and thought it was a really neat job, was able to tour Methodist and get kind of a little bit broader perspective as to what that flight team truly does, and decided, well, maybe that does seem kind of cool flying. I actually got to go on a flight and it was absolutely fantastic, and decided, okay, yep, big paramedic goal of mine. I'd love to be a flight paramedic. So transitioned from that small rural EMS system to Marshalltown, who at that time was one of the leading paramedic services in the state of Iowa, and got some incredible experience there. A lot of folks down in the metro kind of call Marshalltown Little Chicago, so to speak, just because we see some true metro cases and metro volumes in a critical access hospital, which is pretty unusual. So we're pretty set up to get a lot of good experience. So once I had, I think it was about 3 or 4 years of experience with Marshalltown, I had applied and actually didn't get hired the first time I applied, but they kept my resume and I went down and flew along with them for a fly along a couple more times. And so once they decided to go ahead and officially open up that base, then I was invited to get a position as a flight paramedic with them, and have been flying with them ever since. And about 2 years ago, post-COVID, I had the COVID virus and had some cardiac complications from that, some irregular and fast heartbeats that required some medication. And then a couple of years ago, ended up with a stroke. And at that point in time, after recovery from the stroke, decided maybe I need to step back from a job that requires flipping from days to nights, and some 12-hour shifts and some 24-hour shifts, and a lot of stress. Flying in a helicopter is a lot of metabolic demand on a person's body, just at baseline, which makes me appreciate how much demand it is on our patients' bodies as well. So I had approached our local ER and the director and just asked if she had ever considered having paramedics in the ER, especially somebody like me with the type of experience I have. I felt like I could be a pretty valuable player. And she took a chance on me, and I've been there ever since, working in the ER alongside the nurses, doing basically everything that the nursing staff does, with the exception of what I call Southern innovation. So I'm not a Foley kid. It's not my scope of practice. So there are certain skills that I can't do, but then I bring other skills to the table, like innovations, so I can
Hmm.
innovate patients alongside the physicians, which is helpful as well. So that's kind of my background.
There's a lot going on there. We're gonna have to take a step back and dig a lot deeper. All right, so let's go back a little bit. So how did you get interested in being a paramedic?
My best friend's mom was actually the first female firefighter paramedic for Waterloo Fire Rescue, Judy
Cool.
Rottinghouse. And
Cool.
when I got to know a little bit more about her career and what she was doing, I was kind of hooked watching her, getting to hear her stories. Being a paramedic was definitely where I wanted to seat my roots at.
It's certainly a lot faster pace. I think if you hang out in the ED, ER, whatever you want to call it, very long, things are moving quickly. As a physician, I'm seeing things, I see a lot of patients, so it's fast moving, but I'm not seeing trauma, complicated over and over and over fast coming at you. And so I think if you were looking for a job that was high paced and exciting, I think that is the way to go.
I agree. I feel like I have squirrels and they're at a rave in my brain. And so being in the emergency room department environment works very well for me.
It works. It works. So let's go back. You said you had COVID and you had some cardiac complications, some tachycardia. I actually had COVID and I had tachycardia and they couldn't figure out what was going on for like a month or two. And then mine just kind of fizzled off and went away. But yours did not go that direction. So what were your symptoms, or what kind of walk us through what was going on?
So after the initial difficulty with just having the COVID virus in general, I had all of the typical symptoms that they talked about on TV, not being able to smell. In fact, I had a wicked cough and I had told my husband and kids, hey, why don't you guys just like hang out elsewhere? I made my husband sleep on the couch because I'm a terrible wife, but I'm like, I feel like this might be a little bit more than just like your average cold.
Mm-hmm.
And had been around enough sick people in the ER. Like, I'm just, I know that I will end up eventually being prone to getting some sort of illness from somebody that I took care of,
Yeah.
despite all of the hand washing and everything else that I was doing. And of course, he was like, "Oh, you're fine. It's a cold." I'm like, "This one just kind of feels different, but I'd appreciate it if you slept on the couch tonight." And the next morning, woke up just feeling absolutely miserable, and had him go out and grab a home COVID test. And the first one I took was actually negative. And so I told
Mm-hmm.
him, said, "I still don't want you around me for 24 hours. I want to retest tomorrow and see." And immediately pop positive. So it was body aches. I had a fever of 104 plus despite Tylenol and ibuprofen, and it was just kind of weird. So
Yeah.
ended up getting through that initial infection, and probably a week post where I would say I felt good enough to like be back at work and whatnot, fever free without any interventions. I started having some wicked chest pain. I'm like, oh, it's different. I've never had chest pain in my life ever.
Mm-hmm.
And I had actually had um, chest pain the night before my stroke
Hmm.
and didn't think anything of that either because that was probably 4 months ish, 3 or 4 months post COVID infection, where I had been battling with this chest pain off and on. I'd seen my regular practitioner for it. I was having, she thought maybe runs of SVT, so they put me on metoprolol and
Mm-hmm.
gently increased my dose. And I'm currently on 100 milligrams and living life fine, high on the
Mm-hmm.
hog on that. But the night before my stroke, had some wicked chest pain to the point where I told my husband, I was in tears. I'm like, this is different. Something's wrong. I need to go to
Hmm.
the ER and be checked out. And so they, I went to the local ER. They did all of the normal chest pain protocol. I knew exactly what to expect. Go ahead and give me my aspirin, start my IV. I'm going to be here for 4 hours because you have to redraw my troponin and
Right.
all that fun stuff. And they actually drew a D-dimer on me too, and that was elevated. And I wasn't on birth control. I'm not a smoker. There was no signs that would point to a rational reason why my D-dimer would be elevated. So they did a PE study and that came back fine. And so it was kind of by the time they had given me some IV medication, my chest pain had resolved. And it was one of those like, we don't really know why you had chest pain. All of these markers seem okay. Yes, your D-dimer's high, but your PE scan was negative. You're a medical professional. You know what to watch for. Let's send you
Yeah.
home. And
Sure.
later on that day, I had told my husband, I made lunch for him and the kids. Like, I just feel real tired. Of course, it never is going to be at, 9 o'clock in the morning when you're having these issues. It was 11 o'clock at night the night before. So I didn't get home until wee early hours in the morning. And just told him, like, okay, I've fed you, I've watered you. I'm going to go lay down and take a nap.
Yeah.
And didn't fall asleep right away. And so I thought to myself, well, I'll just scroll through TikTok and, mindless scroll for a little bit, and then I'll fall asleep and take a nap. No big deal. And when I went to roll over on from my left side over to my right side, nothing moved. And I went, that's weird. I just really must be tired. And so I tried it again, and my left side didn't move again. And I thought, that's not good. Something's
Yeah.
wrong. And so I tried to yell for help. And we're a gaming house. Like, I've got an Xbox upstairs, and so does my husband. And we had been on a Call of Duty kick. And so I knew that he was going to be downstairs playing with our friends, and they were all getting online and whatnot. And my daughter is actually going to hop on my Xbox and play a little bit too. And so I tried to yell for help, and I couldn't talk. And that really scared me. So I was
Yeah.
able to grab my phone with my right hand and text what I thought was help me to my husband. And it's actually German. And when I translated it from German to English, it actually says help me. I've never spoken German an entire lick in my life. I have German
What?
ancestry. I don't know how. I've got no reason for that to
That's
have happened.
crazy.
But he got that message and it didn't make any sense to him. So he
Yeah.
comes up to take a look at me, and I can't respond to him. I can't move my left side of my body. And now I have a 40-some-year-old guy who is standing in my bedroom, panicking, repeating, because I could still hear everything. I could still understand. My comprehension was there. And he
Yeah.
kept repeating, is this really happening? Am I going to have to call 911? And the paramedic inside me is screaming, yes, please, dear God, call 911. I need help.
Right.
So it was our local EMS crew that showed up, and they were fantastic. The fire department guys showed up, the police department guys showed up, and they were all great. And of course, they all know me because I've worked in this area for years. And I can only imagine how difficult that had to be for them. But the paramedic on actually called for flight from my house. And so they had a helicopter coming up. They take me over to the ER. They scan me. I don't have a bleed. So then it's this question of, do you get TPA? And I've flown a lot of post TPA head bleeds to know, like, this is a big deal. This is a big drug. There's a lot of complications that can happen with it. It's not, nothing in medicine is for free. And so again, I can't talk, and my husband's having to make these decisions. And,
Yeah.
he was like, whatever, you guys are the professionals, whatever you need to do. And I'm very thankful that they went ahead and gave me that TPA, because once the aircraft got to Marshalltown, lifted and flew me to Methodist, it was probably close to an hour post TPA administration. And I was starting to be able to move my left side a little bit. And my speech, I was trying to make sounds. It was very stuttery. I knew what I was trying to say, but I couldn't quite get it out. And by probably about 10 o'clock that night, if I remember right, I had speech and I was able to move the left side of my body. So I'm very thankful for all of that stuff that went on. But that's like
Yeah.
going from having that initial infection to dealing with post-COVID stuff to, I was 36 when I had my stroke, a 36-year-old female who's having chest pain. I look at that a little bit differently being in the ER now versus when if I would have been working in the ER prior to that. It's just uncommon for a middle-aged person that age, that, female. I like, you've known me. I came to you when I had Achilles issues because I was training for a half marathon. Like, I'm a pretty healthy kid at baseline and would not have expected anything like that.
Yeah.
So
Man, that's so scary. I mean, that's so unpredictable too, like you said, in that age and that health of population to have such a complication like that. But I think, I'm no expert, I'm no immunologist or infectious disease, but what a crazy, weird, novel virus with so many different things than what we've ever experienced before with prototypical viruses that we treat. I don't typically treat a lot of viruses. I treat a heck of a lot of bacteria, but not virus and fungus, but not a lot of viruses. But what a really scary situation. So I'm glad you're better. I'm glad that went how it went and you were able to speak a little German there for a minute. That's crazy. Like
Yeah.
you hear stories about that, like someone speaking a different language, like what's going on. Maybe your brain is a lot more stuff in there than we actually have conscious access to.
I can
Something's going
only
on.
imagine.
Yeah, it's crazy. So thanks for sharing that story. That's a very interesting story. That scary stuff. I'm glad you're okay. So let's move forward to the happier stuff. So you came to me with what we would call bunion pain, and walk us through kind of how your pain started and how it got to the point where you sought medical evaluation. Because I think a lot of people have, well, like you with the chest pain in a different world, but they have aches and pains and stiffness and soreness, and they don't really want to go see anybody. They just think, oh, I'll try this or try that, or maybe it'll go away. But what were you doing, and how did your pain in your foot start?
So before I saw you, probably a decade prior, I think I was in my 20s, and that was a fun time for me. So timelines blur a little bit, but I actually had a bunion on my right foot that was fixed surgically by another physician. And that one had started out with me running, and my big toe joint started to click, and then I had a lot of pain, and it was very painful to walk. So that's truthfully when I went to seek medical evaluation for a possible surgical intervention on that foot. And so that was kind of my litmus for my left foot. It I had some soreness in that big toe joint, but it wasn't anything that wasn't kicked by, the occasional NSAID usage, which I didn't have a problem with at all. But then when it got to be consistent and constant, I started feeling that clicking in that joint. That to me was like, oh, I had that in my right foot. I had surgery on my right foot. I felt much better. I
Mm-hmm.
probably need to start thinking about that. And
Sure.
previous to that, I had had some plantar fasciitis issues that I had sought treatment for with you as well. And so I think part of it for me was already having that established relationship with you and working with you in the ER and knowing kind of your demeanor and knowing where I was at in my lifespan. Also knowing that I'm in my 30s and watching the older population go through surgery and have more complications. They struggle more to recover from those surgeries. I'm like, okay, A, I've got enough PTO built up in my bank. B,
Yeah.
this is causing me enough trouble that I feel like I should seek some intervention from a podiatrist. That's enough of a green light to me to go have a conversation with somebody and be like, yeah, I think it's time we start talking about it. So that was really
Sure.
what led me to start that conversation with you.
Sure. So let's jump into your x-rays here. So these are your x-rays here. And so for anybody just listening, we have what I would call probably a mild increase first intermetatarsal angle. The sesamoids are definitely lateral deviated, but not a lot of incongruency of the first MPJ. So some first metatarsal head prominence medially, maybe dorsal medially like we typically see. Not a very significant bunion, but a moderate atavistic cuneiform. So we've got the angular deformity of the medial cuneiform and sending the first metatarsal medially. So when you come in with these type of x-rays, typically when I see someone with this type of x-ray, because it appears mild radiographically, we tend to start with some simpler things. Hey, have you tried shoe gear changes? Hey, have you tried a little cushion, a pad? When someone's had surgery on their other foot, they typically know, hey, I've tried all that stuff. I've been down that road before. It didn't really work. I ended up with surgery, and that kind of, cut to the chase and say, okay, well, if it didn't work on the other side, maybe we can just kind of cut out the middleman and go right to surgery. So anybody looking at this, there's a few different ways you can fix this. So we can do a head procedure out here, or we can do a base procedure. So I typically favor what's called a lapidus, which is a first tarsal metatarsal joint arthrodesis or fusion here. So what is your recollection of us talking about procedure selection? Do you have any recollection of that?
Yeah, I mean, you walked through, if I remember right, I think there were three different options you gave me. And you had even gone as far as to ask me what type of surgery I had on my right foot before, because I know I had told you whatever it was, I don't even remember the doctor's name, but whatever he had done for me before, like he fixed it and it's great. And I've been walking on it without any pain whatsoever, for at least a decade.
Mm-hmm.
And you were able to evaluate the scars on my foot to be able to really get a good idea. And, I told you I've got a couple screws here. I know they made a bigger long incision here. There was some shaving involved. Um, as a flight paramedic, if you got feet, I like to cover them with a blanket. If it's not attached, I can bring it with.
Yeah.
But that's really the extent of my foot expertise.
Yeah.
But I know walking through those options that you gave me and what my end goal of being able to go back to walking, working out, riding the bike, being active again, that was my ultimate goal.
Sure. So let's jump ahead here. These are my intraoperative images, fluoroscopic guidance. So I chose to do an MIS lapidus, so minimally invasive surgery lapidus. So on the top left there is the insertion of the MIS burr. So the small burr, make a small dorsal lateral incision at the first TMT and a fairly medial first TMT incision. I stick the burr in, isolate, try to find the joint, verify on fluoroscopy that you're at the right level. And then bottom left there, you can see that we're angling the burr to try to resect the atavistic cuneiform, the angular component of the medial cuneiform here, because essentially we're going to take out this wedge of bone so that when we translate the first metatarsal laterally, you can see, skipping ahead here, that it's going to sit flush. It's going to sit straight across. So the MIS burr goes in. I stick the burr in one portal, resect out under fluoro, take it out, go the other portal, resect out. And then when I'm done, I can flush through one portal and all of the cartilage and bone comes out the other. If you make one portal, it's difficult to flush all that cartilage out of there. And ideally, you'd like to get all that cartilage that's going to prevent good fusion at the first TMT, get that out of there. So with two portals, you're flushing through one, getting the cartilage out through the other, and that seems to work well. The central picture here is pinning. So once I found the optimal position, I've burred out both sides of the joint, taken down the atavistic cuneiform, realigned the first TMT, I'm pinning it into place. This is the hardest part of the procedure because I don't have 5 hands, even though I wish I did. You're holding it and rotating it and translating it and getting back into proper alignment. So once I've done that, I've pinned it into place here. And then on the right, you can see I've got screws across the first TMT, crossing screws, proximal to distal, distal to proximal. And then I like this crossing screw that goes from the first to the second TMT as an anti-rotational screw and actually continues to provide a reduction of that over time as the patient begins walking again. So we're going to breeze through those because I'm boring you, Heather. And we're going to get to the final views here. So these are the crossing screws at the first TMT and then the first, second base crossing screw. So what I want to pay attention to the surgeons listening, are the alignment, the first, second, and metatarsal angle with good correction. We have resection of the medial eminence, dorsal medial and medial eminence of the first metatarsal head. Significant improvement in the sesamoid position. And then we've got a lateral. We want to verify that we don't have any metatarsus elevatus or any plantar flexion. We want to make sure that that first metatarsal shaft is exactly parallel to the second metatarsal shaft, because if it isn't, you're going to cause either a varus or valgus or forefoot complications by either dorsiflexion or plantar flexion in the first metatarsal. So ensuring that you have parallelity, that's a big word for me, parallelity of the first and second metatarsal there on the lateral view is very important. So these are your x-rays. So let's talk through kind of what it was like leading up to surgery. I'm going to kick these x-rays out of here and we'll go back to talking about what it's like from your perspective.
I think the biggest thing for me as a patient is recognizing how much out of office time that looks like. As you know, I've got two different jobs. I work in the ER and then I work as a flight paramedic. I know that I need to be 100% on my game at both. My flight job is a lot more physical than my ER job. So I know what that looks like from that angle. And I knew that having surgery on my foot was going to put me out of the flight rotation for a minimum of probably 2.5 to 3 months. And I
Mm-hmm.
felt like that was a good solid estimate of time, which, you know, obviously is a little bit gray and can fluctuate. But knowing that, it was kind of a big deal to make sure that I had everything covered for that period of time that I was going to be out, because there's a lot of education, there's a lot of skills, there's a lot of meetings and stuff that I'm required to be at. And while that stuff I can be at, some of that stuff is still out of reach. So pre-planning to take care of certain things. We have a lot of different things that are required of us. So making sure that I had all of those ducks in a row just for
Mm-hmm.
my part-time job. And then my full-time job, I actually worked to coordinate my time off, so to speak, off of the floor with our emergency department assistant, or EDA. So knowing I was going to be unavailable to cover shifts for, you know, probably 3 to 4 weeks roughly. So I'm out for a solid month, not stepping foot in the hospital at all. And then when I come back, I know I'm going to come back with work restrictions, because we had those conversations and I had previous experience from that other foot that I had done.
Mm-hmm.
So being able to look at my PTO bank, look at the financial estimate that it was going to cost to have the surgery, how much was it going to cost for me and my family to be off of work for those 4 weeks. You know, I fortunately have a job that has short-term disability, so some of that will be covered, but the rest has to be covered for PTO. So how much PTO do I have in my bank? Incidentals, I have kids. Who knows what's going to happen when? So making sure I had a little bit of cushion if one of them decided to break a bone, or, you know, they got sick or whatever, making sure that all of that stuff was covered. So it's, for me as a patient, I think I have a unique perspective because I've had surgery that was elective before. So I
Mm-hmm.
have kind of a ballpark idea, but that was also 10 plus years ago, and a lot of things have changed since then. I'm in different careers now. So being able to have enough forethought to look through all of that and kind of pre-plan and make it work for me was probably close to a 4 or 5 month process preoperatively.
Yeah, there's a lot that goes into it, and I think that's one of there'll be a lot of times where I say this during this episode, but there's a big distinction on how a patient perceives the same procedure as the surgeon. I was joking earlier that a surgeon looks at their schedule and they say, I have an ankle, I have a calc, I have a first IPJ, I have a cyst removal or something like that. And I'm just trying to figure out, okay, when am I going to get lunch? When can I be done? What am I going to do this afternoon? And the patient is literally moving piece by piece their entire life and rearranging everything in their life to make this possible. Sometimes people are having family come into town. Sometimes they have to find a different child care situation if they're one that cares for the child, or like you said, multiple job arrangements. So, and it's hard for us on this side, the surgeons, to give an accurate estimate. People always ask me, how much time off work? Okay, now we need to talk about, what do you do at work? Do you sit at a desk and type? Because that's a lot different than I get people that are linemen, not football, but climbing power poles and doing electrical work high in the sky. And so there's a big difference in when those two people with the same exact surgery can return to work. So it's a little bit difficult for us to predict that, because we don't know, well, if you normally do that, could you do this, or is it all or nothing? And one of the things that no one ever teaches you through any school or residency or anything are these little details like that. Well, how long am I going to be off work if I do this job, this job, this job? I don't know. I mean, even to this day, someone asks me and I just say, plan on 3 months. And if it's before then we're both going to be happy. But if I tell you 6 weeks and it's 6 weeks in a day, you're going to be mad and asking me why it's taking so long. So I tend to overestimate sometimes and say, longer than what I think, and then we're both happy when it isn't quite that long. But you do want to try to give an accurate estimate because they are planning their life around this and telling their job, hey, this is how long I need to be off for. So I think that's an interesting distinction, that your life and my life leading up to the same event are very different in terms of the planning, because I do the surgery, I don't know, 45 minutes maybe that took, I have no idea, 45 minutes, an hour maybe. And then I'm done. Like, I'll see you next week and then I'll see you later, but you're the one that's got to now hobble around and change your life. So let's talk about the immediate, or let's talk about the day of surgery. Are there any nerves going into that, or what do you've had surgery before, so maybe not, but what are you thinking as a patient on the day of surgery?
I think I might have a little bit of a unique perspective simply because I come from that ER trauma environment where we're dealing with people that were living their lives like normal, and then bam, all of a sudden it's completely different and their world is upside down. And you want to talk about trying to give them an estimate. Good luck. It's not going to happen in the ER.
Yeah.
Somebody rolls in with chest pain and all of a sudden I look at their EKG and they're having a STEMI and we got to ship them on down the road. Well, hold on, can you wait 45 minutes for my wife to come? No, we can't. Time is muscle, and we need to get you on the road now. And so then it's extra phone calls and everything else. But again, taking that into account, for me, yes, absolutely, we're nerves rolling in. I mean, obviously after my stroke, there's been a lot of different conversations with my husband, and I have a medical power of attorney in place. And for a 38-year-old to have that in place is kind of odd. And he knew my wishes, if I'm down on the table, like I'm ready to go have coffee with Jesus. I'm ready for that, whatever. And again, as a 38-year-old, having that conversation with your husband's just kind of weird. But I also come at it with a unique perspective. Both of my parents are gone. I just buried my mom a year and a half ago. And so my perspective of that is very skewed. But, the night leading into it, prepping and, do I have X, Y, and Z in place? It's on this day, which means I need to double check in the morning on our way to the hospital that so-and-so is going to take the kids, and, touching base with their mom. Oh, yep, that's taken care of. And there's a lot of different check boxes that kind of help negate those nerves, so to speak. But, this is a procedure that I elected to have done. So it's my decision to make sure that everything is in place. And there's always risks of complications with anything that you do. And working in the ER, it's constantly watching that risk and that complication walk through the door. So it's a skewed perspective, so to speak, but also helps me make some very clear, definitive decisions on my healthcare and my well-being, and knowing that, like, I'm done putting up with my foot hurting for every single day. I'm ready to have that fixed so I can move on and continue forth. And I'm not going to run a marathon by any means. I'm a corn-fed Iowan. A half marathon was on my bucket list and checked off. But, being able to maneuver through my day-to-day and not have any issues, that's really what the end goal was for me.
Yeah. Working in the ER, you think that the complication rate of anything is 100%.
Yeah, 100%.
Everyone here has a complication. The complication rate has to be 100%.
Yep.
That's all I see are complications. Surgical complications rolling back into the ER. So let's talk about right after surgery. How much pain did you have, and how did you control your pain?
Right after surgery, the nerve block was chef's kiss. I loved that. It was great. My husband threw me in the car. I don't remember the car ride home. I just remember, taking a nice little snooze on the couch, and I woke up and my foot's still numb and I got my bulldog on my lap and life is good. And I'm like, okay, how long ago was surgery? What's my next step? Trying to make sure that I'm staying ahead of the pain. So I had oxycodone for that, and all was well and good until the next day at about, I think it was 1 or 2 o'clock in the afternoon. I actually made a phone call to the clinic because the nerve block had worn off, and I had been taking Tylenol. I was icing, I was elevating. I had taken as much oxy every few hours that you could. And I was still to that point where it made me appreciate the people that come into the ER with post-op pain. I understand why. I get it,
Mm-hmm.
because that was
Mm-hmm.
wicked.
Yeah.
And I remember talking to your assistant on the phone, and I'm in tears, and she's like, "I'm so sorry. Hold on. I will talk to him. Just hang on. Let me give you a call back." And she was amazing. And you were super great. Like, this is your game plan. We're going to do this, this, and this. And within probably 4 or 5 hours, it was certainly very tolerable, and I had no more issues. I definitely wasn't expecting that kind of post-op pain.
Mm-hmm.
Obviously always an option could happen, but was not expecting that. And I think I felt more bad for my husband because I was not handling it very well, and I was pretty unkind, and so I had to make up with some Reese's peanut butter cups after that. But
That'll make everything better.
right?
Yeah. Yeah, it's tough. I mean, I think sometimes you've had surgery before, so maybe not you, but in general, I think sometimes people underestimate how much something is going to hurt. I mean, I'm going in, I'm cutting bone, I'm shaving bone, I'm drilling, I'm putting screws in there. I've never had surgery except for my tonsils. It doesn't count. No drilling and whatever. But I've never had. It sounds horribly painful to me. It sounds terrible, and so it makes 100% sense. So when people call, not just you, but anybody, like, "Hey, my foot hurts," and you're like, "Yeah, you had surgery," but it's hard to get ready for that. I imagine of like, especially because you wake up and you're like, "Oh, my foot feels great. Is this what it's gonna be like?" And you're like, "Just wait, give it a minute." Give it a minute, because the floodgates, the nerve block is sitting there holding back, and it's building up, and then here in a minute the floodgates are going to open. And so getting through that kind of initial rush of pain, I think, is the hardest part from that standpoint. So trying to get that pain under control can be difficult, but not impossible. I don't remember how much you were walking on it, because I've changed my protocol a little bit as time goes on. This is a newer procedure, doing it minimally invasive, that is, and letting people walk on a little sooner. But what was your post-op protocol? When did you start kind of moving around?
I had my first post-op checkup with you a week post-surgery, and then it was, I think, 2 or 3 weeks after that. Um, and if I remember right, by that next follow-up, it was one of those, we're going to be off for X amount of time, and then I want you to start putting a little bit of weight on it, but using your crutches. And it was definitely I felt like a very nice gradual increase in pressure and movement to the point where I could walk without crutches. And I'm going to be completely honest, I'm a medical person. We're the worst patients.
Yeah.
I would love to tell you that I was the perfect patient and I followed your protocol 100%.
Yeah. Nobody
No,
does.
nope, nope. I definitely tried to push it a little bit too, just because, I feel like I know my body pretty well and can read that line of, this is a pain that's acute because I'm doing something wrong, versus this is pain because you are using it and working it and it's getting a little bit swollen, and that's stuff that will go away eventually. And so
Mm-hmm.
I kind of use that as my litmus as well. But it definitely was a solid, like, move from no weight bearing to a little bit to, yep, like, if you're gonna get up and stand, like, bear weight on your heel but not completely on the flat of your foot, and whatnot.
So when you started walking on it more and more, how much pain did you have compared to when you were off of it? Did the pain increase significantly when you first started putting pressure on it?
Not that I remember, truthfully.
Okay. So not too bad.
Mm-mm.
That's a good sign of stability in there, and that things are healing appropriately. So, because sometimes people start walking on it and then it gets more painful and more swollen, and you're a little nervous, like, maybe that is not quite ready to be walked on yet, since everyone's a little bit different. So you did have, so we'll call it a complication. You did have quite a bit of stiffness of your big toe joint, and so when I do this procedure, I do the MIS approach through the first TMT and then a small incision over the first metatarsal head to shave the bump down. And I've had a few patients get some stiffness of the first MPJ, I think because I'm keeping them off of it to allow the first TMT to heal, the bone to heal. But in doing so, they're not moving their big toe, the first MPJ, and we're getting scar tissue adhesion to the capsule because of excision of bone. Now, I do try to put a little bone wax in there to prevent that, but I have had a few people get some stiffness. So um, what did you do about the stiffness, and how long did it take you to really kind of go away?
A lot of movements, like grasping my toe and moving it back and forth, standing and bringing my foot down and putting a little bit of pressure on that big toe and then curling it behind. I think out of everything, this motion is fine. I still have a little bit of stiffness when am bringing my big toe back, so I've got a little bit of pressure on that nail bed, so to speak. But
Mm-hmm.
even that has gotten a lot better. And then I am do what you're not supposed to do, Google, and making sure that I've got some good home exercises to do. So the toe crunch with the towels and stuff like that, those
Mm-hmm.
are things that I was also doing at home, which I think in between you seeing me for that first time, you're like, ooh, that's really stiff. You got to work on that. To that
Mm-hmm.
second time when you saw me and you went, yeah, buddy, that's so much better. I think
Yeah.
all of that combined made a big difference. So, I do put a little bit of that onus back on the patient too, to be asking the questions and doing some research and, being very upfront about what are you doing at home? Be honest if you're not doing it at home, because if you're not doing it at home, why? Is there something
Yeah.
we need to try to do different? Is it, pain? Is it, I don't have stuff at home? What do we need to do to get you to the point where you can work on that?
Yeah, and I've changed my post-op protocol now because of some of those stiffness issues, that now I really focus on people taking the boot off and moving their foot as much as possible. If I did a good surgery and those screws are holding like they should, moving your foot in air or even resting it down on the ground and doing some gentle range of motion exercises of the big toe should not disrupt anything. So getting some early range of motion at the first MPJ after first TMT fusion, I think will be very helpful to prevent some of the scar tissue adhesions at that joint, so that people don't have to deal with that stiffness first and working through that. Maybe we can prevent that somehow. But that's kind of one thing that I've changed to try to prevent that. So is there anything that you would have done differently during the surgical process?
Gosh, not that I can think of. I actually, I know that you saw it in clinic. I got a shoe lift when I was in that boot walking a lot to help prevent any
Yeah.
issues with my hips and my back. And that
You
thing
mean
is
for the
actually
other foot?
for that other foot. Yeah,
Yeah.
that's actually traveled to I think 4 or 5 different people now who have also been placed in a boot and went,
Yeah.
huh, that really that you don't think it's a whole lot of difference, but it is. And so
Yeah.
making that change, I would recommend that to anybody that's going to be in a boot and that is going to be walking. That, and then I hopped on the Zon and I bought a elevation pillow to make sure that I had enough pillows and support and stuff for those first few weeks to really make
Mm-hmm.
sure that I was elevating it appropriately.
Sure. So, all in all, a pretty smooth process aside from the postoperative pain after the nerve block wearing off. So, it's interesting to kind of hear the patient's perspective, because we deal with patients all day long, but we don't get as in depth. We don't have time to go in depth with all the patients and help figure out all their life things that go into it. That's up to them to figure out. But just understanding that there's a lot going on the other side of this same interaction, I think is helpful for physicians to understand. So let's spend a little bit of time, if you are willing, to go through some interesting stories, either in the ER or flight paramedic or whatnot. Do you have anything that stands out in your mind as interesting or unusual or crazy that, you go to a party and you're like, you're never going to believe this?
Um, the ER is always interesting. You never know what's going to walk through those doors. And like I mentioned before, here in the town, Marshalltown that I work in, it is truthfully like metro level stuff in a critical access hospital. And it is truly impressive what my colleagues and the physicians that I work with and the mid-level providers, what they're presented with and how they take care of those patients and getting them to definitive care.
Mm-hmm.
I I know that there's a lot that I have not seen yet. As far as flight goes, I mean, they don't call the helicopter for stub toe all of the time.
Oh, what?
So
Come
I
on.
know it's weird.
Podiatry. They should throw me on the chopper. Get
I
in
would
there.
love for
Oh, with
you.
subungual hematoma here. Let me see what we can do.
I would love for you to come do a fly along, and that would be the one time
Oh,
that we would have a foot related injury, and you would
there we
just be over
go.
there like, "Yep, this is what you should
Yeah.
be doing." Um, we on the flight team, I am credentialed as a critical care paramedic, and I have my board certification as a flight paramedic. So we're trained to do certain procedures like chest tubes. I can do
Mm-hmm.
surgical crikes. We used to be able to do pericardiocentesis,
Yeah.
which was insane to me. I
Yeah.
saw it done once. I think that I probably drink enough caffeine that I'm not sure that you want me doing that. And then it really fell out of favor because our teams just weren't doing it enough to make it
Mm-hmm.
medically necessary to have in our skills, so to speak. But within my first year of flying, I had assisted in placing multiple chest tubes. I've had the one and only surgical crike, knock on wood, that I've ever
Mm-hmm.
done, which was absolutely terrifying and crazy all in one. That shift was a 12-hour shift with a seasoned partner. And I call that one my 12 hours of trauma because we had three different trauma cases. All three were trauma related cardiac arrests for different reasons. And it
Hmm.
was just insane and heavy.
Yeah.
Um, Being based out of Des Moines, I actually get to fly with all three of our teams. So that includes our NICU transport team and our pediatric transport team. So no matter the age range down in Des Moines, one of the adult crew members goes with. So I have to be trained in neonatal resuscitation and PALS
Mm.
and all of that different stuff. And our team does everything. I mean, I've been a part of prepping for flights that involve the Impella, ECMO, NICU transport, nitric, a whole bunch of different stuff. So it's pretty
Everything.
neat. Yeah, it's pretty neat. Um, we get to fly all over, not just in the state of Iowa. So it's been probably, I think 4 years ago, there was a lot of flooding over in the Nebraska area, and I was up in Fort Dodge. They actually launched us to go over to Nebraska and help evacuate a hospital
Hmm.
because there were no ground ambulances that could get to it, and they had a hospital full of people that needed
Wow.
to get out of there. So being a part of that, flying kids to Children's in Omaha, down to Kansas City Med, um, over to Chicago. We have the ability to fly fixed wing every once in a while too, so that's pretty neat. And a lot of those flights are typically NICU babies going to like CHOP, different places like that. So
Mm-hmm.
yeah.
So how does that protocol work? So obviously there's, let's say it's something relatively commonplace like a car accident. And so you're obviously not first on the scene because someone has to show up first, assess the situation, and then call the chopper. So there's a local EMS crew that's on the ground, and they determine whether or not this is something that needs the flight paramedic team. And so what's the cutoff? How do they make that decision? I'm sure if you do it enough, then you just understand and it makes sense. But what are some of the protocols for, let's call the flight chopper as opposed to just taking them straight to the ER locally?
When we talk to the ground EMS agencies and the fire departments and the police departments, we let them know that anything that's considered time critical is really something that you should potentially consider utilizing our area ambulance services, simply because rural Iowa is spread out so far. And when you talk about trauma, we only have two level 1 trauma centers in the state of Iowa, one at Iowa Methodist and one over at University of Iowa. So
Mm-hmm.
you get into a bad car accident that really needs that level 1 trauma care in Hardin County, you are a long ways away from either one of those level 1 trauma centers. And so
Sure.
those ground crews are really tasked with being able to identify, is this something that requires immediate resuscitation, like we need to go to the local ER and the aircraft can meet us there? Or is this something where we're paged out and we hear enough of that information and we know it's going to need that higher level of care, so we go ahead and launch that helicopter right away? It's a pretty common misnomer that, aircrafts, as soon as they're launched, the patient's getting a bill. And I can tell you with our service, there's no bill unless we actually actively fly a patient. So being able to make sure that local EMS agencies understand that has really helped with being able to launch us quick. Because I tell everybody, I would much rather be 5 minutes from a scene and you guys decide and determine, you know what, we actually don't need a helicopter. We can turn right around and I can go back to my cup of coffee. I'm happy to do that every single time.
Yeah.
But I would much rather be 5 minutes away from your scene with a really sick critical patient and getting ready to land versus 25 minutes away yet because you're like, oh, I'm not sure if we need them yet or not.
Yeah.
And so
Sure.
I would say, honestly, throughout the state of Iowa, all of our ground crews are phenomenal with being able to identify which of those patients are going to meet that critical access need versus needing to page for a higher level service to get them to where they need to go. And that includes, strokes, heart attacks, traumas, you know, OB in rural Iowa is getting more scarce and more scarce. I've delivered more babies in the local ER than I have in my entire EMS career. That's not something I ever thought that I would do, but it speaks volumes to the lack of OB care in the state and what that does with folks. Now, I will tell you, flying an OB patient's a lot different simply because we need to be able to determine, is that mom going to deliver immediately? I don't know if you've seen the inside of an aircraft, but it's tiny, and we're really set up to take care of one patient at a time.
Right.
So we have certain guidelines in place to be able to make sure that who we're flying is safe for a multitude of reasons.
So let's say, maybe you know this, maybe you don't, but let's say that it takes a car 60 minutes. They're 60 minutes away. And in Iowa, 1 mile is 1 minute. So in the big city, no, but when you're 60 miles away, you're like, well, that's 60 minutes. I know exactly how long that'll take me. How long would it take a chopper? What's the time conversion between ambulance to chopper?
We usually tell folks that our flight time is typically about half of what a drive time would be. So it usually takes from the ER in Marshalltown to Methodist downtown, probably anywhere from 53 to 57 minutes. That's a 23-minute flight for us. So that's a good frame of reference to keep in mind for what that flight looks like versus ground.
Sure. And when someone needs, when someone's having a stroke or having a STEMI or something, that's a lot of minutes that make a big difference. So
it is. And, aircraft usage, it's expensive. I mean, having been flown for my stroke, that was a $70,000 aircraft bill. Fortunately, the people that flew me worked really, really well with my insurance. And because I was seen in the ER and I had an ambulance bill and then I was flown and then I was in the ICU, like I'm fortunate to have really good insurance. Not everybody is in that situation. And the out-of-pocket requirement from me was incredibly minimal. So that is something to keep in mind. But I will tell you, the folks that billed me, the Air Methods is the company that owns the aircraft that flew me. It was actually our folks across the street, Mercy, that came to pick me up, and they were really, really good to work with. They kept me informed when I got the initial bill. I immediately panicked. I called them. They have a case manager, like, yeah, I'm your person for your flight. Take a breath. Nothing's even gone through yet. I'm going to keep you apprised. If you have questions, you just call me. I will answer everything. So they were really, really good to work with. And that level of customer service, when you receive something like that after having gone through all of those things and wondering, like, how am I going to afford all of this? I think we have a lot of people in rural Iowa that are one healthcare scare away from being in a world of hurt financially.
Yeah.
So I recognize it as a flight paramedic. Like, I don't have to deal with any of that billing stuff. I just get to come in and take care of sick people. And I absolutely love being able to do that. Really, really love being able to do that. But that other portion isn't lost on me either.
Yeah, that's tough. Okay. Interesting. Well, I appreciate you joining me here on this episode of Paw Patrol. I appreciate you taking the time.
I loved the opportunity to come on. I will tell you that I've told everybody that I'm on the podcast, and I have done my due diligence shy of standing in my street with a sign with your logo on it telling people to subscribe. So hopefully you got a
Oh,
few more followers over the past couple of months.
it doubled from 2 to 4.
Sweet. It's
Yeah, we're
working.
rolling now. We're rolling. All right, I appreciate that. All right, I'm sure I'll see you soon, but thanks for joining me on this episode of Paw Patrol.
Sounds good. Thanks for having me.
All right, thanks everyone for joining me. Dr. Dikis, we'll see you guys next time. Bye.